Okay. On the onset, let me thank Dr. Mahapatra and Manoj and the organizers of this World Congress for giving me this opportunity to be with you. I appreciate the perseverance of Dr. Mahapatra for last so many years behind me to be here. That has made me to be here today. Mm-hmm. So my topic today is a cardiac transplants in India, the current status and how good our results are. And I just can finish this topic by saying that it is as comparable as globally it can be. And that I will show you the results of published results of our country. Let me talk first on the recipient donor challenges and rejection and immunosuppression and the global scene, because each one of these factors has affected our outcomes. And we have reached to an excellent level as compared to the global scene. Mainly because we are standing on the shoulders of giants all over the world, as well as stalwarts in India that I will share with you. So in current challenges and the current status of the heart transplants, we have getting now older patients and older donors. We are getting more patients on MCS. We are getting more patients who require combined transplants, like other multi-organ transplants, and are more sensitized candidates. And I shall go by one by one to all of them. So let's consider the old recipients and the old recipients first. In this, we are getting elderly recipients mainly because we are getting a delayed reference. So there are a lot of medicines which are coming and guideline targeted medications, as we discussed for a whole day in the morning today. We are getting these patients late as compared that patients will be registered earlier. These delayed referrals had made this multi-organ failure. The ARNI has given another subject of topic because many of the patients who have got ejection fraction of 15% and 20%, they never ever improve their ejection fraction by ARNI or any other medicine. I have not seen any medicine which is improving. We are talking of the ARNI when the ejection fraction is 45% or 40%, that becomes 50%. Yes, I understand. But the patients who are referred to me are at 15% and on months and months of ARNI with LVITT of more than 6 and 7 and 8 millimeter, and then they deteriorate so fast that their pulmonary hypertension increases, they become multi-organ failure than only heart failure. The patients which remain low for a long time on this problem with infections, which are seen more commonly after the COVID, especially, our majority of the patients are coming with PRA positive, which previous to COVID era, we were getting them the PRA negative. And then the financial constraint, as they have spent a lot of money in the medicines as well, and the patients financially not able to do the transplants. Now, second topic I was going to say is that many of the patients who have to land up putting on mechanical circulatory support. And we have presented this paper, published this paper with temporary mechanical circulatory support, our insights and evolving strategies. And that I will touch them as we go ahead with the So the combined organ transplants, here we have done heart, lung, heart, liver, and heart, kidney. Not only the heart. And that same thing again, that their lung gets damaged not because of the primary lung pathology, but because of the heart, the liver, and the kidney as well. So as sensitization of the talking about, many patients are getting sensitized. Mainly they are female patients where they got multiple pregnancies or infections or abortions, and they develop these antibodies. And especially after the post-COVID era, we are seeing a lot of patients coming with PRA positivity. We have done virtual cross-match. If you go in Europe and in America, then these patients usually have all the recipients, HLA typing is done, and majority of the patients, majority of the donors, HLA typing is also done, and it takes few hours to cross-match and see HLA typing like we do in live kidney transplants, right? So here we do not get an opportunity to do. However, we are the first time in India we have done this virtual cross-match as a prodigal savior of the cardiac transplants in India. And one case portrays India's first reported successful cardiac transplant utilizing virtual cross-match based on the patients with the PRA positivity. And we have done it successfully. Patient is still alive 4 years after down the line. The rejection and immunosuppression, initially we used to think that the rejection is less, but now somehow the rejection also is the problem, mainly because compliance to the medications of immunosuppression is not as good for financial reasons, for social reasons, and other reasons. And some of the patients, they just stop their treatment, rejection treatment or immunosuppression treatment, and will land up in a severe rejection. And all the things which are done for the transplant and everything, donor and everything, this goes in a dustbin. Coming for a biopsy is also difficult for some patients with which tells us whether it is the CMR or AMR. CMR can be managed easily, but the AMR is very, very difficult and very costly to manage in India. We are coming out with the cell-free DNA and RNA, and we are doing a research on it, and we are doing the prospective randomized study that liquid biopsy instead of myocardial biopsy. The PGR is a difficult topic to advise. The more donors, we are not getting the more donors. The donation after circulatory death, we are trying to evaluate now. So no geographic constraints will be available for them. So the ex vivo perfusion platforms we are evaluating and under research by Dr. Bala and their team, and the more equitable donations, heart transplantation and allocation policies revisions are in progress with the ROTO and NOTO systems. Now, if you see this International Society of Heart Lung Transplants, the risk factors for 5-year mortality, you will see the significant difference. Significant difference is there, whether it is ischemic cardiomyopathy and born. And almost 27% of our recipients from our series are in this group, that they are high risk for death. If you look at the surgery of the heart transplant, it is the same, there is no difference. But more centers are now getting licensed. I have no against in that more centers being licensed. But if some patients are doing more group, more recipients, the more volume of the transplants, the team development and the other factors and research and documentation database will affect that. And the more logistic problems will be solved better if there are few centers than multiple centers. In Indian results which are published, we have published 25 patients of pediatric heart transplant in our first 5 years of series with no mortality. And the excellent results, we have seen them, and still the 5-year survival, if you see of them, we have got still 95.6% of the survival, and those patients who have stopped immunosuppression, those pediatric patients, they stopped immunosuppression, no family backup and background. So we have death in them, which we cannot avoid, but we have taken some measures to overcome that. This is the excellent paper from our India, which tells the medium-term results of heart transplantation and 257 patients by Dr. Bala and the group from MGM. And if you compare this, Dr. Bala's or the Indian results as well as the International Society of Heart results, there is a difference that the 1 year mortality is around 80%, and the 5-year success is around 80%, and the 5 year is around less than 70%. Just less than 20%, as compared to 1 year survival of this group, which is between 85 and 90%. So this is the one which is not been. This slide explains that these patients do not come in our classical recipient group, but this is Intermax scoring 1, 2, 3, and that is why we have got a high mortality. So the previous slide, if you mention, this is the mention slide when the patients are in a patient's year, are majority of the patients not in Intermax score 1, 2, 3, because they are supported heavily by early registration and good follow-up, and by the mechanical circulatory support very early, and listing also very early. Here, that is not the case in India. And that is why we see majority of our patients go to Intermax score 1, 2, 3, where they are very, very sick patients on mechanical circulatory support, ICU admitted, and whatever the donor comes, we have to go for them. We don't have a choice to wait for a good donor in such cases, because my patient is on a deathbed anyway. And in this patient, the early mortality is very, 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 very high. This is a slide explaining the same thing, that expected hazard and the relative hazard ratio in Intermax score 1, 2, 3, 4, 5. The 5 means very good. 1 and 2 means patients are really, really sick. So you can see 5% mortality as compared to here 0% mortality in international scoring. So this is our results of pre-transplant. I got just out of 98 patients, 14 patients required before transplant ECMO. Those who got transplanted here, 6 patients, there is a 100% success rate. But those who could not get a transplant, when they were on ECMO, 8 patients of them, they all have died. So in mechanical circulatory support means LVAD plus ECMO or IABP and Centrimag. If that is the case, then 24 patients were there. 95% who were there on LVAD, 2 or 3 patients, they survived and they recovered. So it was recovery, complete recovery without going transplant. And that is why this mortality is little, or the success rate is 95%. But here the transplanted patients, all the patients who had mechanical circulatory support, who underwent transplant, they have a 100% success rate. So this explains that waiting list survival and transplant mortality with the mechanical circulatory support. Nobody likes mechanical circulatory support, but in our hospital, in our India, we realize that those patients who are dying on a deathbed, and if I had not done anything, they would have died. On them, we have put a mechanical circulatory support. My waiting list, which was the waiting list survival from 75%, that means 25% was a waiting list mortality and 81% survival. And here it is exactly same. The transplant mortality has decreased because of mechanism. This is the All India Institute report of lessons learned from the transplant. This is infection, rejection, and PGD. They are the 3 main causes of the mortality or the early mortality in these patients. This is a 5-year survival, and if you can see the 2008 to 2013, the survival is much better than the previous decades of the transplant. And that is the improvement is not in surgery, but improvement is in immunosuppression and understanding of it. And this is a beautiful chart which explains the same thing. This is a decade-wise, and this is this decade survival rate, which is far, far superior than these 3 decades of the survival. That is the improvement in the understanding of rejection, PGD, and control of infection is much better and much superior. The graft rejection in infection, multiple organ failure, and rejection, or the post-transplant lymphatic disorder are the major 4 causes of the deaths. This is my last slide, which tells that improving the Indian results, early referrals is very important. The proper workup and follow-up and maintaining their other organs is very essential, can be done. The selecting donors to avoid graft dysfunction is very, very important. If I have got a more pool of donors, as well as early registration of recipients, reducing the MCS for intervention is very important for us. The increasing donor pool is financially also. Increasing donor pool is a key thing which we are addressing, but because of the COVID, it has gone back. And identifying centers doing volume work, again, for database, research, training, and logistic and financial is very, very important to catch up with the same results what we see in the Western world. And we are learning from them, and we are catching them up as early as we are standing on their shoulders. Thank you very much.